Dr. Mosti, a very well-known angiologist working and doing research on the management of venous ulcers. And I think he's going to give us a different perspective on how effective compression is and what new tools we have available. So Dr. Mosti is going to talk to us about advanced techniques in venous ulcer management. Dr. Mosti, please take it away.
Thank you very much for your presentation. And actually, together with Sylvain, we thought to change a little bit my title, because, you know, there are many advanced techniques today in cancer treatment, like, for instance, ultrasound therapy, electrical stimulation, growth factor, a lot of them, but none of them is very well supported by evidence-based medicine, while compression is, as you know, the only one treatment who got the grade 1A in evidence-based medicine. And so I will speak mainly about compression and specifically about the new treatment of compression. I completely agree with you, Nikos. Venous ulcer is a multifactorial disease, but even in your presentation, you put a lot of stress on hemodynamics, and everybody knows that we have an important point here, because almost all venous ulcers are due to venous hypertension, ambulatory venous hypertension, that is both when the normal standing pressure doesn't decrease during walking, or even when it increases due to venous obstruction. So we need to counteract this venous hypertension, because, as you correctly say, Nikos, we have also a lot of consequences produced by venous ambulatory hypertension, up to skin changes, inflammatory problems, etc., and finally ulcers. The compression is important to counteract the ambulatory venous hypertension, and as ambulatory venous hypertension means at least 70-80 millimeter of mercury in standing position, you need to exert a strong compression, and strong compression can be exerted without pain. So together with kind of comfort only by inelastic material, because inelastic material has not elastic recoil, and so it is not painful. If you stretch it very much, you can just have a temporary tightened sensation, but the feeling is almost always comfortable. And you can see here the pressure curve. The pressure increases very much during foot dorsiflexion or in standing position or while walking, but the pressure at rest is quite comfortable. What happens with this kind of pressure? It happens that the venous pressure is overcome by this external pressure, so restoring a kind of valve mechanism. And in this way, inelastic compression is effective in decreasing venous reflux and increasing venous pumping function, and so reducing ambulatory venous hypertension. As you can see here, this is not possible with elastic material, because elastic material is never able to overcome the intravenous pressure, never able to restore this kind of valve mechanism. And I don't say ineffective, but not as effective as in elastic material in controlling venous hypertension. So as the first pathophysiologic factor in ulcer pathophysiology is ambulatory venous hypertension, the most effective procedure in reducing ambulatory venous hypertension should be the most effective modality in ulcer treatment. Now we have another device, not only in elastic bandages, but also adjustable compression wraps. And there is a new one in honor of our organizer. You see the Cool Flex by Sigvaris. You see that pressure curve produced by this device is not very different from the compression pressure produced by an inelastic compression. So even this material is able to overcome the intravenous pressure and restore a kind of valve mechanism. For the same reason, they are probably, because we don't have data, they have more maybe the same hemodynamic effect. There is no reason why two devices exerting the same pressure couldn't have different hemodynamic outcomes. And the great advantage of this material is they are very easy to apply. It's just enough to educate the patient. Usually, I would say 15, 20 minutes are enough to educate the patient, and the patient can also manage the compression by themselves. And you certainly know how self-management increases the compliance of patients. This is a study we published some years ago. We applied a vector up on this patient, and we asked them to readjust the bands, the vector bands, when they felt a tightness, looseness sensation, and they reapplied the vector ups, and they came back after 2 days, and the pressure you see is quite nicely maintained after 2 days. These devices have been shown to be very effective in ulcer treatment. There is a very old study dated 1999. They were shown to be more effective than Unabut, than 4-layer bandage, another paper from Lecter and Villavicencio in 2005, and also more effective than 2-layer bandage. This is our Italian study published in 2020. These devices were shown, these particular devices were shown to be, to exert, so to say, to have a stronger stiffness compared to what is on the market from more time. So static stiffness index is higher with this device than with the old devices. And this is also, it was also shown to be very effective in edema treatment. And unfortunately, we don't have a publication, but a report from Hari Krishna, maybe you know him, is the new president of the World Union Wound Healing Society, and he reported this study some time ago, and you see he treated with this device 70 patients. The ulcer size reduced dramatically. It was about the half of the ulcer size after 12 weeks. Also, the leg volume reduction was significant after 12 weeks, and the treatment was very well tolerated. And I included here some of his pictures. You see very good outcome with this vector up. So my conclusion is that leg ulcer treatment requires a strong pressure, possibly by inelastic material. Inelastic bandages are very effective, but you certainly have the same experience I have. They are difficult to apply and require an important education. Adjustable compression wraps are effective as well and easier to apply, allowing self-management. Thank you very much for your attention.
Dr. Mosti, every time I see your presentations, I'm amazed with how much science there is behind compression, and very few people know this. I'm really amazed. Excellent talk. So if I understand, well, is it about the material and not about the amount of pressure?
No, it is about the amount of pressure, but the amount of pressure depends on the material. So you need to use inelastic material to have this kind of pressure curves. I would say quite comfortable at the rest, but very effective during standing and walking. And you know that our venous pressure increases during standing. So we need a strong pressure exactly when we stand up. And this kind of material, I would say that adapt to our body change of position.
Giovanni, how do you decide how much pressure to apply in a given patient?
So this point of arterial involvement already came out, and the response by human was excellent. If the patient do not have any arterial involvement, you know that you need to apply a strong pressure. For strong pressure, I need more than 40 millimeter of mercury, but especially if you are using inelastic bandages, even higher, because we know that inelastic bandages lose pressure over time. So maybe after 2 or 3 hours, if you applied, for instance, 60 or 70 millimeter of mercury, you will end with 40, 45 millimeter of mercury. So in this case, you need to apply an even stronger pressure at application. With these new devices, able to maintain the pressure because you can readjust the device when you feel a looseness sensation, you can start from 40, 45. If you have an arterial involvement, woman spoke about class 2 compression stockings. I would say that you can use very easily also bandages or velcro wraps, but in this case, you need to reduce the pressure and not go higher than 40. I would say below 40.
There is one, Marcus, there is one question from the audience.
Okay. So they're asking for your comments on the use of wraps, especially in countries where the weather is hot, like India and the Middle East.
Yeah, there's a problem with any kind of compression device, but we cannot do advertisement in this presentation. This is a scientific presentation, but our guests are producing, our organizers, so to say, are producing a fantastic device with holes. And this, if I may say, I don't know if I'm allowed, but I will try and I hope you will not put shame on me. The Cool Flex is a very good device with a lot of holes, allowing transparency, and I think that this device can be easily used towards a hot climate.
Thank you. And we have one more question. Human, you wanted to say something?
No, that was the question.
So there is a question actually for you, Human. So what is the age, if there is such an age, that you would consider a patient not a candidate for angioplasty and stenting in chronic venous obstruction? Is age a barrier?
So let us start with a lower age. If a patient comes to me, and I have few of those patients, 14 years old, 13 years old, and they have a kind of PTS, but they are doing well with some painkillers and physiotherapy and sport, I do not stent. Why? Because the stent size I need now will be small probably later. So I see how tall the father is, how tall the mother is, and if the high of the patient is nearly achieved, that I say with 16, then I can do the recanalization and put probably the 16 and 14 millimeter stent. If we go to the higher age, I would say a very mobile and fit patient with 70 years old is suffering, or my patient was 64, 68, suffering from ulcer or advanced PTS or venous claudication and is impaired in her or his daily life, I would do the recanalization and stent. But let us say if a patient is immobile in the bed because he's multimorbid or she's multimorbid, I wouldn't go for recanalization because of venous claudication or swelling. Only in a case of non-healing ulcer or if the leg is really heavily affected and in danger. So there is no clear limitations, but of course, a very young patient should be avoided of stenting because that stent won't be the proper size later.
Woman, I have a question
Giovanni.
regarding age. Don't you think there are very old patients, very active, very smart, very intelligent, and there are young patients completely abandoned in bed and so to
Yes.
speak, very bad condition. So
Absolute.
this is the limit for.
No, there is no limit. The condition is the limit. You are fully correct. I have also patients, of course, it is difficult with 1-2 outpatient visits to see how non-compliant the patient is or how compliant the patient is. But there are, as you told, younger patients, they do not do well. You recanalize, you stent, they smoke, they do not take the stockings, they interrupt the anticoagulation, and they come with a reocclusion. And of course, you have to take care and do not recanalize them anymore. But there are older patients who are very active, yes. But in general, our patients, I think you can agree, Makis, are from 20 to 60,
Right.
the main part.
Woman, another two questions, if you may. First question, in all the presentation and all the recent publication, I don't see any more recanalization of femoral vein, just iliac obstruction.
Mhm.
So it is now clear that this procedure is very effective just in iliac, suprainguinal, so to say, obstruction.
No, not supra.
Second,
You are correct. You are fully correct. But
suprainguinal.
yeah, but very important is not to put the threshold inguinal ligament. The threshold is confluence of the common femoral vein, where the femoral vein and deep femoral vein come together. This is the threshold. Below, distal to this, that means femoral vein or deep femoral vein, we would love to prevent any recanalizations, regardless the technique, because we know the failure rate is very high. But above it, that means from the beginning of the common femoral vein, which is infrainguinal, and the inguinal tract, and the iliac tract, and the cava, the recanalizations, if the inflow is given, are really very successful if done, performed technically correctly. Makis.
I would like to. No, go ahead, Dr. Mosti.
No, Giovanni, go ahead.
Same side. You certainly remember that there was a lot of debate if going on with this procedure up to a very few years ago. Now we have new data supporting the effectiveness of this procedure in patients with this kind of obstruction.
Yes. Makis.
No, I know I have two surgeons, very good surgeons in front of me, so your response will be certainly positive. But anyway, if you have some criticism.
Makis.
Well, if you're talking about iliofemoral obstruction, I think we have good quality data. The higher quality data actually just came out from the Athens Center, the Stevico trial, indicating that recanalizing the iliac vein will improve the patient's quality of life against those just receiving anticoagulation. And we are waiting for the results of the trial that is now the C-track trial coming.
And best.
But for the femoral vein, I don't think we have any good data to justify recanalizing femoral veins. And to step on that, Nikos, if we recanalize the femoral vein and turn the obstruction into a refluxing femoral vein, are we making things better or worse?
No, nobody knows, Marcus. But the thing is, for recanalization issues, the femoral vein is going to occlude. It's a matter of time. So it's just wasting time and energy which are unnecessary. Maybe it can make the patient even worse because by extending the obstruction. That's why I should leave it alone.
I think Yeah, I think only Nikos and Giovanni and Mark, it's only in a case of really non-healing ulcer. And there is no other help, and the conservative treatment has been exhausted and performed very well, and it doesn't help, then you can take in consideration doing something.
With one of these patients, we've done a small publication. We just ballooned the entire SFA.
Yes,
right?
yes.
And then some people actually heal the ulcer. I don't know how, but they
Yes,
do.
but the ballooning should be a long duration ballooning under aggressive anticoagulation, ACT higher than 300. 3 minutes ballooning each segment. Maybe it helps.
Okay, we have one more quick question for Dr. Mosti before we move on. How are you handling patients who are not compliant on compression?
This is a very good question. I cannot respond because I don't have non-compliant patients. I think, no, I'm not joking. No, I'm not joking. I think it very much depends on the material you use and on the expertise of the bandager or anyway people who apply compression. Because if you apply a good compression, if you use the proper material, the compression is extremely useful to the patient. The patient will realize immediately that he or she is improving because edema is reducing, ulcer healing, the feeling, so to say, the comfort is better. So there is no reason to stop with compression. Obviously, if you treat patient without any symptoms, for instance, a lot of colleagues prescribe stockings in patient with varicose vein, asymptomatic by the way. Obviously, this patient will stop with compression. It is not useful at all. If you use wrong compression, because if the patient has, I would say, a large leg and you prescribe a small stocking, the patient will be not compliant. If you use the wrong material, because, for instance, apply a bandage, you make some strangulation or some negative effect, obviously the patient will stop. But I want to recommend, this is very important, if you use the right compression, and if you are able to apply a good compression, compliance is absolutely great.
Thank you, Dr. Mosti. I think the microphone is now on you, Sylvain.
Yes, thanks a lot for the first presentations. I think, Marcus, you have your presentation now also.
Yep, let me share my screen. Okay, thank you for giving us the opportunity, Sylvain, and thank you, Sigvaris, for supporting this event. I'm going to give you a preview of what we have been working on over the past year to have the Venous Symposium Europe happening for the first time, inaugurating it in Athens, October 17 to 19. Let me start with this nice video. It's one of the most popular meetings in the US for the past several years. And with Nikos and Tony, and they're Greeks in their blood, we thought it's a great opportunity to transfer the legacy they have built up over the years in the US to transfer it to Europe. I have recently moved to Athens, Greece, and I have an excellent collaboration with Human Jalayev from Athens. And I felt this is the right person to collaborate and build a similar project, a similar meeting in the European environment.
Well, this is a distinct meeting compared to other meetings. We as educators over the last 20 years or so have been trying to create meetings which are unique, that would allow participants to go back home, learn things that they can go back home and use in daily clinical practice. And I think that's what VS has contributed in the last 15 years, and that's what it's going to contribute when moving to Europe.
So, in my opinion, if you're a vascular surgeon, you're an IR, you're a phlebologist, you're a dermatologist in the field of active in the field of phlebology, you should attend the Venous Symposium Europe because all aspects of phlebology are going to be discussed.
Well, I think more or less they said it all, but let me tell you that the story starts 15 years ago back in New York, where Nikos, who's with us today, and Tony were the co-founders of this brand. It's the most popular venous meeting right now in the US, the Venous Symposium. We used to say Venous Symposium New York. Now we just call it Venous Symposium. And I have been privileged to be part of the faculty since 2017. And when I moved back in Europe, I thought this is a great meeting. We need to get it to Europe. And here we are now, fast approaching in 3 months. Myself, Human Jalai, Nikos and Tony, along with our leading experts, Steve Black, Armando Manti, and Giovanni Mosti, we are going to kick it off on October 17, 19. We are going to have a lot of key opinion leaders, almost 60, maybe even more faculty are going to present about 100 presentations in 2 days and a half, venous and lymphatics only. We're going to have 23 scientific sessions, superficial, deep, lymphatics, compression, ulcers, and aesthetic phlebology, novel technologies, video sessions, 4 live imaging. Patients on stage will come and share their story. You're going to see Nikos Labropoulos performing live ultrasound, and the audience is going to be sharing their opinions on how to best treat these patients. We're going to have 4 Meet the Expert sessions on cutting-edge novel technologies, and we're going to have a keynote lecture. It's going to be Andrew Nicolaitis, a well-known father in venous research. We're going to have 4 workshops for people who want to deepen their knowledge in stenting, in venous thrombectomy, in IVUS. We're going to discuss about novel ablation and sclerotherapy techniques in other workshops, as well as a general, all you need to know on superficial and deep venous intervention. But it's not only about education and training, it's also about having fun. For the lovers of running or even walking, we're going to get them at 8 o'clock in the morning on Thursday to Panathinaik Stadium. This is where the first Olympics took place. This is 10 minutes away from our venue. We're going to get in there and run and get some nice pictures. We're going to have a great party on Friday night by the beach. And on Saturday evening, at the end of the meeting, people will be able to enjoy a nice planetarium show, because the planetarium is actually the venue of our meeting. So for people who are attending this webinar, please feel free, submit your IVUS case, submit an abstract, submit your best venous ultrasound image. You're going to get the opportunity to present on the podium. Please register as soon as possible. At the end of this month, the early bird registration is going to be over. So the sooner, the better. And I'm going to end
From Greece,
with
let's
this.
say Athens.
Live in New York right now. So if it's work related, I would say New York. If it's fun and education, I would have to say Athens.
Athens, of course. I love, of course, New York.
Athens, of course.
Oh, Souvlaki, come on.
I have a soft spot for good steak, so I'm going to go with steak on that one.
Of course, Souvlaki.
Souvlaki, of course.
Always Acropolis.
Acropolis for sure.
I love both. Times Square with Makis Avgarinos. We were together last week in Times Square. But come on, from the history, of course, Acropolis.
Join us in Acropolis.
Both together.
I would say take a choice wherever you want to go. You want to go to New York? Fine. If you want to really enjoy the blue sky, the friendly environment, and the amazing atmosphere of Greece, come to Athens.
VS Europe for October, VS New York for May.
I will hopefully go next year's both, but I am more Venous Europe. I am from Europe. Let us start with Venous Europe.
Okay, so Athens wins for now, 54, and We're looking forward to seeing you all. If you enjoyed today's webinar, you're going to see a lot more. You're going to have fun in Athens, October 17, 19. And having said that, we need to thank again Sigvaris because people who are attending this webinar are going to download the certificate and going to get a huge discount for registration. Sylvain, you want to talk a little bit more about this? How people are doing this?
Thanks a lot, Marquis. Yeah, through the great collaboration, we really have the possibility to offer this discount if you're registering for the Venous Symposium in Athens. And you will get a certificate for participation in this MOH, and with this you can register then on the page of the Venous Symposium and get the rebate. I had already mentioned it during the introduction that Sigvaris will be actively present at the Venous Symposium in Athens on October, and I just wanted to point out to do events. First of all, we have the Sigvaris booth there on place, and it will be booth number 3. And I encourage you already now, if you are there, please visit us and have a look at our newest compression products and solution for patients with venous lymphatic disease. And beside that, I wanted also to point out to an interesting live on stage workshop, the session 10, where we will also be actively parting in this event with Giovanni and Nikos, having 2 patients on stage, one with varicose veins and the other one with ulcers. And Giovanni will put them into elastic and inelastic compression materials from Sigvaris and show the differences regarding resting and working pressure depending on the compression that they are wearing. That will be really interesting. I'm really looking forward for that, and I think it was a great preview of the Venous Symposium Europe, and I hope that our attendees have the interest to go there also. And I would like to thank all you as speakers for the great presentations, and especially you, Marquis, for the great moderation of the event. And I'm looking forward to meet all of you there in live also.
Well, see you all in Athens. Thank you
Great.
so much for being with us today.
Thanks a lot also.
Thank you.
See you. Bye-bye.